It.
Yes.
Yeah. Because your screen is not visible. Yeah, it is coming.
Real
Not yet.
Is it visible now?
No, not yet.
No.
Right.
You send it to me or I'll share.
Yes, I'm just doing that. Is it visible now?
Yes, yes.
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 Sure. So, firstly, good evening, everyone, and thank you so much for your time. It really means a lot of. It's a pleasure to have everyone on your board, especially Dr. Richa Poria. Thank you for your constant support for all our KT Live sessions. So, without any further delay, we'll be starting off with our today's session. So, just like to introduce our course director and key moderators for today. So, we have Dr. Ichapuria on board. He is the director neurology at Sayadri Hospital, Yerwada. Sir is the first neuro ICU and neuro intensive care of Pune. He's also been a senior pioneer in thrombolysis treatment for stroke in India and has given lectures in more than 300 places and workshops on stroke. He's also a member of the ISA and the organizing president of the StrokeCon 2012 and the organizing president of ISA Stroke School. Sir is also the founder of the Pune Stroke Group and the ex-president of the Society of Neurosciences, Pune and Maharashtra, Academy of Neurology. He is also the principal investigator for many multinational stroke trials like the Perform Stroke, BrainsGate Stroke, BG12, and cortical venous thrombosis Interact. And Sir has also been awarded as the health icon by the Times of India Group. Thank you so much, sir. It's a great pleasure to have you on board.
Thank you. Thank you so much for the kind introduction.
Next, we have the very esteemed Professor Dr. Kameshwar Prasad. Sir is the head of Department of Neurology, Fortis Hospital, Vasant Kuch, New Delhi. Sir has been awarded Padma Shri and is also the former professor at the All India Institute of Medical Sciences, AIMS, New Delhi, and has over 40 years of experience in the field of neurology. I'm so sorry to interrupt. Is the screen visible yet?
Yes. Yes, it's visible.
Yes. Sir is also a pioneer of evidence-based healthcare in India and a key contributor to Government of India National Health Program since 1997. Sir has also been the founding president of the Indian Stroke Society and has represented India at multiple national and international platforms. He has also served as a member and chairperson on various expert committees. Sir, with his international and global role, Sir has also been the current member of the WHO Strategic and Technical Advisory Group Brain Health. He has also been an esteemed member of Multiple Sclerosis International Federation and also the member of the WHO Meningitis Guidelines Group, the member of the World Stroke Organization, and also the member of the World Federation of Neurology. Sir also has authored more than 4,000 publications, including research papers, book chapters, and books. And also, it's a great day to interact with him as we celebrate his birthday. So, we wish you a very happy birthday from all of us, sir. Thank you so much for being on board on this auspicious day as well. Next, we have Dr. Prasanna Kasegaonkar on board. Sir is the chairman and consultant neurologist of CNS Hospital in Solapur. He has also been a member of the American Academy of Neurology, member of Indian Academy of Neurology, member of Maharashtra Academy of Neurology, the Association of Physicians of India, member of the Indian Academy of Physicians Solapur chapter, and also the member of Solapur Private Hospital Owners. He has a huge teaching experience of about 5 years in the Department of Pediatrics, and also sir has been a professor at VM Medical College and CSM General Hospital, Solapur. Sir has also been accredited with multiple awards, including the Healthcare Professional of the Year 2017 Neurology, the Luminaries Award 2018, the Dhanvantri Ratna Puraskar 2018, and also the Aadhar Maharashtra Bhushan Puraskar of 2018. Next, we have Dr. Makrand Kanzalkar on board. Sir has been
So there's something wrong there. Don't waste time now. Go ahead. Stop this. You have written someone else's CV. You stop it now.
Okay, thank you for the very, very kind invitation and the introductions. I'll introduce Dr. Makran Kanjalkar, who is a eminent neurologist from Aurangabad, and he has worked there for many years and has done human work.
hello.
And
Yeah,
because
am
he's
I
very
audible?
interested in yoga and the brain and meditation, and he has integrated all that teachings of yoga and meditation into neurology. So it is always a pleasure to listen to him, and he's very erudite and very interesting to talk to. So welcome, Dr. Makrand Kanjalkar, and Dr. Kameshwar Prasad, are you here? Yeah, it's a great pleasure to have Dr. Kameshwar Prasad. He's the most eminent neurologist of India, and he's done a lot of work for stroke. And he was really the first one really to push tenecteplase in the world market. And against great opposition, he did that. And we are all very highly indebted to him for pushing it when, there was so much anger, opposition, fighting, whether tenecteplase was better than actylase or whether it should be used. So all credit to him. And also we are very happy to have Dr. Prasanna Kasegaonkar. He's been on this group a number of times, and I think each time we have learned a lot of things from him. So welcome all the moderators, and uh, we are very happy to have Dr. Vinayak. I think you presented 2 or 3 times before, no?
Yes, sir. 2 times before, sir.
Yeah, 2 times before. And I'm sure he's enjoyed himself. Otherwise, he
Yes,
wouldn't have
sir.
come here the third time. And each of the 2 times that you have come, we have learned from you. And we are very happy to have you here.
All
So I think if you can start, who is going first?
yes,
Kalpita?
me only.
Dr. Ichhapuria, I'm Dr. Kameswar Prasad. I have
Dr.
also
Kameshwar,
joined.
I just introduced, I mean, you were introduced formally, but I
Okay.
introduced you as
Thank
the
you. Thank you.
pioneer of tenecteplase in India and your great contribution towards this amongst very vociferous opposition. So all
Thank
congratulations
you.
to you, and
Thank you.
very, very happy birthday to you also. So it
Thank
is
you.
very,
Thank you.
very nice of you to come and spend your birthday with us and give us your pearls of wisdom.
Thank you. I
Yes.
just could not stop this because you are there and Tenecteplase is there.
Yeah, yeah. And the way tenecteplase has evolved and has captured the world attention, and that is all because of India and especially you, because
Thank you.
I know what things you had to face and what things you had to do to get
Right.
it on board. So
Thank you.
many,
Thank
many
you.
thanks to you and many, many congratulations.
Thank you. Thank you very
Yeah.
much.
Yeah. So who's going first, Kalpita?
So
Yes, sir.
Dr. is going first.
Vinayak, you're going first?
Yes, sir. I'm going first, sir.
Yeah.
Just 1 minute, sir. Yes, sir. Is my desktop visible, sir? Yes, sir. Is my slide visible?
Yes,
Yes.
yes.
Yes, sir. So thank you, esteemed speaker, for allowing me to speak one of my stroke cases with you. No thrombus, which I call it as making stroke thrombolysis available for all eligible patients. So, I would like to comment that due written consent for every stroke patient was taken. All consent were individualized, like patient who has concomitant MI or cancer patient who has stroke. Without consent, a baseline plan was to give antiplatelet and BP monitoring. Or if someone gives a negative consent from thrombolysis, we have taken negative consent also from them. That is what we follow. So my case is the case of a spillover. So this is a 37-year-old hypertensive male since last 1 year. He was on erratic medications. He didn't have any addiction, but he was a government employed and recently joined. He had right side weakness that was there since 1 month. He used to have repeated episode that last for few minutes to 1 hour. Means since last 1 month he had around 6 episodes of right side weakness and slurred speech, and each used to last 2 to 5 minutes. But on 5th December, this episode lasted for a prolonged time. That he had a slurred speech that lasted for about 2 hours, for which he went to the hospital. His MRI was done on that day and he has spontaneously improved. He went home. He didn't took any medications. While on 6th December, the next day, 8 a.m., when he woke up, he again, after doing some work, he developed slurred speech. By 11 a.m., he had this right arm paresthesia while he was on duty. And while on duty, he developed this hand grip weakness and walking issue, for which he got admitted at a nearby center that was 100 kilometers away from Aurangabad around 7 to 8 p.m. At that time, wherever he was admitted under a physician, they were trying to get to some neurologist, and he was referred to us by 4 a.m. on 7th. Means the stroke that started early morning day, by overnight they reached us at around 4 a.m. So he was conscious on examination. There was a global aphasia. When we observed it at morning, so 4 o'clock, he had right hemiparesis and NHS was 17. So this was my chart. We usually do the complete NHS and see the total scoring was around 17. This was the images. This was diffusion flare images, which is showing a right MCA territory frank lesions, and they were progressing. Actually, when he came at around 4 o'clock to us, the stroke was still worsening. And these were the flare images. There was few of the images lesion that are present on flare also. So there was some amount of partial mismatch, diffusion versus flare, which we can see here. There was some amount of diffusion changes seen. This was the angio of the patient. The MO was completely occluded with the sparing of the temporal branch. So the 37-year-old male who had an onset on 6 December around 8 to 11 a.m. reached at around 4 a.m. to us. He was not affordable for thrombectomy. With due explanation and detailed discussion, they agreed that apart from antiplatelet, we can plan him for extended trocholysis, and they gave a specialized consent for that. So onset to needle time was around 24 hours. We gave other option that we can keep him on antiplatelet, we can plan for thrombectomy, which they refused. So they gave a fairly consent to go for thrombolysis. So this is a critical time for a neurologist, whether beyond 4.5 to 6 hours should we go for a thrombolysis. But in this case, as a young stroke, we agreed and we decided to go for thrombolysis. So post lysis, this was the position of the patient. This was taught by one of my consultant that when he keeps his hand over the head, suspect that he has some part of bleed. That is what we clinically think hand or head signs. These were the CT of the patient. So CT showed, sorry. So CT showed that there was some amount of hematoma in the 1/3 area of the right MCA territory. But frankly, there was some amount of tissue of the MCA territory that we were able to save in this patient. Considering the hydrangeal cultivation, this hematoma goes under PH1 classification, that is parenchyma hematoma type 1. But sparing this patient did not have any other clinical worsening and his NHS improved really well. This was the post images on 7th day and 21st day of the patient. I just want to show these images. So this was the 7th day image. He has improved considerably. This was the image. This was the gate that was observed in him. So this was the 7th day and this was the 21st day. So he has improved considerably. So the prime factor which I consider for better outcome of a patient is logistic. As soon as possible to shift the patient from casualty to MRI and get him lyse as early as possible. Dosage is also important. The tentative that this give also a dosage chart which according to the patient we can really give a crystal clear dose of the tentative to the patient, helping in better stroke outcome. And post lysis monitoring of blood pressure and NIHs always help to monitor the patient. So important point on my case of stroke thrombolysis was time can be extended based on CT perfusion or a more commonly available MRI-based perfusion. Repeated history helps us to increase or decrease the time window. It might be earlier or it might be later. And post thrombolysis BP monitoring always is the keystone for stroke thrombolysis. Thank you, sir.
Yes, Dr. Makran, would you like to comment? Prasanna, did you hear the full case?
Yes, sir. Actually, I joined little late, but then I could get the gist of
Okay,
what
so
you were saying.
you can discuss the case.
Yeah, absolutely, absolutely. Well, first of all, congratulations. I mean, it was a very courageous decision to lyse a reasonably large infarct with M1 occlusion at almost 22 to 24 hours, and the results are fantastic, fabulous. Little hemorrhagic transformation was kind of expected, but then since it was only a parenchymal small bleed, the
Yes, sir.
outcome as
Yes,
expected
sir.
has come extraordinary.
Yes, sir.
So the only thing that was in our hand in this case was just try and bring down the door to needle time, because what happens before the door is totally out of our control.
Yes, sir.
So even that was very wonderfully managed. Both the options, including mechanical thrombectomy as well as IV thrombolysis, were duly discussed with the relatives. So kudos. I mean, everything is so perfect in the way this case has been managed, and a young life saved from his morbidity. So congratulations.
Yes, sir.
Dr. Makran? Dr. Kameshwar?
No, I agree. They did a very good job. So congratulations.
Yes, sir. Thank you, sir.
Makrand, are you there? Yeah. So two or three things. One
Yes,
is,
sir.
that he was getting TIAs before the event. So
Yes, sir.
this is a very, very important message for everyone. Don't neglect TIs. The
Yes.
symptoms are mild, but the disease is bad. So, many practitioners, GPs, physicians, even neurologists, don't send the patient away after just doing an MRI. You should do an MR angio.
Yes, sir.
And so that is one very important thing, and it can save a lot of people many things. So we must take TIAs much more seriously than we do. Now, this chap had about 4 or 5 TIAs
Yes, sir.
before the event. So that suggests a large vessel occlusion, or it can also be a capsular warning syndrome. We don't know.
Yes,
So,
sir.
ideally we should. What about the neck vessels, Vinayak?
They were good, sir. There was
Neck
no
vessels were
major.
good.
Yes, sir.
Yeah.
There was no
So,
severe.
first thing is don't neglect these TIAs.
Yes.
They look benign, but they're not benign. So, it's a bad disease. Secondly, you did the MRI, which was wonderful. And, this wake up trial and this trial has said that nothing should be seen on flare. But I really don't believe that, because that is in the trial. But if we find that there is a significant difference between the DWI and the flare, which there was in this case,
Yes,
then
sir.
why not?
Yes.
It may not improve 100%, it may not improve fully, but why not give the patient a chance? So
Yes.
I must congratulate you that, I mean, see, it is guidelines, but you see, we going outside guidelines is not a crime. And
Yes.
this we have seen so many times. In the flare, you may see a little bit because it's now 22 hours.
Yes, sir.
And unfortunately, we are not able to do the perfusion scans. They are very cumbersome. They're difficult to interpret. So this Chinese trial called Trace, it has shown clearly that up to 24 hours you can treat. They did CT perfusion in their cases, but I think, it's very difficult to do CT perfusion. And if we do a surrogate marker like flare mismatch, I think it is wonderful. And it has been shown clearly by you, Vinayak, that, this fellow has improved.
Improved, sir.
My only thing is that, did you do an MR angio or CT angio after the event, after he
Uh,
improved, to show whether the vessel opened up?
no, sir. Not was able to do post lysis angio
Yeah.
because of his affordable.
So, that would have shown whether I think the vessel opened because obviously that bleed happened. So
Happened,
it
sir.
was a reperfusion injury,
Yes, sir.
but luckily it was just pH1. So
Yes,
we
sir.
don't really worry about pH1. See,
Yes,
it
sir.
is within the infarcted area. Anyway, that area is dead and little bleeding occurs. There's no mass effect. Some headache was there, but that was minor.
Yes, sir.
So, people get scared. Kare re, he'll bleed. This thing, I'll get sued. Kuch nahi hota hai. Nothing happens. And you have very clearly shown that, yes, there was pH1,
Yes,
but
sir.
the fellow improved. And
Improved.
it was the most wonderful feeling.
Yes, sir.
So, this extended time window, I think, and all this time we were saying 3 hours and 4.5 hours. That's all now history.
Yes, sir.
What we would like to say is come as soon as possible. Earlier you come, the better it is.
Better it
We
is.
don't want to treat you at 22 hours. But, in India, the distances are large. People are not using telemedicine.
Yes.
They're not coming in time. They take it very lightly.
Yes,
So
sir.
this public awareness is less. Even doctors' awareness is less.
Yes.
That is a big problem, that we face. That's why we have to do more programs for doctor uh, education.
Yes,
Because
sir.
I find, sorry to say, but I find physicians a roadblock. If he comes directly to the neurologist, he gets treated very fast.
Very fast.
If a physician is involved in between, khalas, you waste another 2, 3 hours. Then you have to make phone call to this fellow, that fellow, take his consent. That is my experience. I don't know what you feel. Makran, what do you feel?
Sir,
Audio,
that's true.
audio.
Yes, sir, that's true. I mean, when it comes directly to neurologist.
Yeah,
Fortunately, in our city now, actually, many patients go directly to neurologist every hospital.
correct.
But as periphery, yes, there are issues.
Yeah.
This is 4
So,
kilometers
the
away
question of
somewhere.
distance and all is there, but in spite of that, in this case, MRI was done outside, you said?
No, sir, we did it at
No,
our
the
facility.
first MRI?
Yes, sir. When he came to the first MRI was outside, sir.
Yeah. So there was MRI facility in that periphery place.
Yes, sir.
So they could have done an MRI there and actually thrombolized and then sent the patient to you.
Yes, sir.
So, that would have saved another 2-3 hours
Yes, sir.
easily.
Easy.
And then, he comes at 4 a.m. You are not at your best position at 4 a.m. Yeah, nobody can be.
Yes,
So,
sir.
but even then, you did it, which
Yes,
is
sir.
extremely creditable.
Yes, sir.
Dr. Kameshwar?
Just 2 points. One is that the Chinese trial, which extended the window up to 24 hours,
Yes.
most important thing is that they did it with perfusion diffusion mismatch. That is one. Secondly, they did not find statistically significant effect in the secondary outcomes. So primary outcome was statistically significant. Secondary outcomes, which are supposed to be more sensitive to improvement, did not turn out to be significant. So we should wait at least for one more confirmatory trial before start applying those results. So that is one precaution I think we should take. And the second thing which I wanted to say is that in a patient like this, you have rightly pointed out that TIAs were ignored. And just to support what you just now said, I think in 1980s, Dr. Achal did thesis with me, and we were studying causes of delay in presentation, and two most important factors came. One was this first physician contact when he delays it, and before that, patient's lack of recognition of symptom also delays it. So these were the two most important factors, and even today, these are the two most important factors.
Sir, you are muted.
Of TIA, treatment and recognition of TIA, how to recognize TIA. Many times the patients come even to casualty, and the emergency doctors are not able to recognize TIA. So, this is some education we need to give to the physicians, that it is not a benign disorder. And invariably, when you are having crescendo TIs like this, invariably within few hours, you will get a stroke. I mean, I've also missed TIs, I must agree, and it is heartbreaking. You miss a TIA and the fellow gets a stroke. Bapre, you can't sleep for 3 nights after that. So, we must train ourselves and we must train other people also. So, I know it was outside your control, but maybe you can call the physician back again and tell him in a nice way that, Are Baba, be careful with these TIAs. They are not benign. And what you have done, I think, is excellent. And it is so this extended time window now, it's not in the guidelines. No, Kameshwar, still not in the guidelines. But it will come. It will come. So guidelines are always delayed by few years. First, these trials are done, and amazingly, the Chinese are doing all these trials, and we are not doing so much. That's a problem. All these new trials are by the Chinese. So very well done.
Yeah, we are far behind Chinese. We
Oh,
better
we are far
do
behind, far
something about
behind,
that.
far behind. अरे क्या trials कर रहे? And the number of patients they are able to recruit, it's just amazing. And so it's just amazing what they're doing. Prasanna, any last words? Prasanna Makarand, anything you want to say?
Yeah. Yeah, I just wanted to extend the point of physician thrombolizing. So, at least in my district, the place I practiced, I have done extensive I've given a lot of talks to physicians for early recognition of stroke, and I always told them that you have to realize yourself. Don't send the patient for thrombolysis to us. If you have any doubt, do an MRI, call us, tell us the symptom, do an MRI, will be available online for you, and you do it yourself. We are there to help. So that sometimes, that is one thing which will save 1.5
That's
2
very
hours.
important. That's very
Yeah,
important.
yeah. We
What
can't be
half an hour? It
selfish
will
and I
save
want
4
to do it
hours.
every day. Yeah.
It will save 4 hours.
Easily. So this is what I have been pushing over last for almost last 6 or 8 years. I've gone to very many places, and I've tried to educate small groups of physicians uh, just to try and save a few more lives.
Absolutely. Very good, Prasanna. I think very creditable work you have done. Makran, anything? Last few words?
Nothing. I mean, this is true. Each and every patient has to be individualized, and rather than not doing, better to do. And sometimes you may regret, but those are very few, rather than because that time won't come again and again. So
Yes,
as
absolutely.
as your
So
hair
I
become
often
gray, you
say,
get more.
when in doubt, thrombolize. Don't find an excuse not to thrombolize. There are many excuses. People will give you 100 excuses not to thrombolize. Late आया, flare में है, ऐसा
या
है,
बीपी ज्यादा
वैसा
था,
है. They will
थोड़ा
give you hundreds of excuses not to thrombolize. But it is better to thrombolize, and you'll be surprised what good results you get. And uh,
earlier about a few
another thing is,
months.
this empty. Had you had empty now, this fellow would have done worse, huh? Vinayak. Good you
Yes.
gave IVT. Sorry, interventionist.
Yes,
So
sir.
they will kill me if they hear this. But many times we find that MCA M1
Yes,
uh,
sir.
recanalizes with TNK.
Yes, sir.
M1 recanalizes. So don't not give TNK. Don't not give. Don't go direct for MT. So I'm a firm believer that you should give TNK prior to MT. Okay, if he doesn't improve, then of course you go. But not everywhere there are facilities for MT. It costs a bomb. It
Yes,
costs so much money. You are saving so many resources by giving this thing. So it's a great advantage in our country.
yes, sir. Yes, sir.
Kameshwar, do you think that TNK works better in LVOs rather than Actilis?
You are asking me?
Yes.
My prediction is that eventually world will know that TNK is a better thrombolytic agent than, and I think still better will come because
Yeah.
there will be work in industry ongoing, I'm sure, which will reduce the risk of hemorrhagic transformation and increase the potential for thrombolysis. Better thrombolytic agents, I think, will come in future, but at this time, if you have to choose between TNK and alteplase, my preference is for TNK, and we have said that in our 2019 meta-analysis also, that at least the incidence of early neurological improvement was better in TNK. But okay, even if you say both are equally good, we know cost issue is a big issue in India, so why not TNK?
But Kameshwar, I have no doubt that it is superior. I have no doubt in my mind. See, all these trials, this ACT and all were done for non-inferiority. They were not done for superiority.
Yeah.
So,
I have the same gut feeling.
gut
but,
feeling. It's a gut feeling, yes.
Yes. Yeah.
But that gut feeling is occurring again and again and again many times,
Yes.
Yeah, but still it's a gut feeling, yes. Okay, let's go on to the next case. Thank you, Vinayak. Very wonderful work. Congratulations. And Every time you teach us something new, huh, Vinayak? So we are very, very happy. Thank you so much.
Yes, sir. Try my best, sir.
Yeah.
Next, we have Dr. Gopal Gulab on board with his case. Sir, if you may allow, can I just present your screen, please?
Yeah, we can see your screen. Now it's gone.
Okay. Thank you so much, sir.
Yeah. 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 Now we can see it. Yeah, Gopal, please go ahead. We can't hear you.
Hello.
Yeah.
Yeah, I am audible now, sir.
Yeah, but little echo is coming, so maybe you
Yeah.
can go a little closer. Yeah, please go on.
Hello. So thank you everyone for giving me this opportunity. So I will start directly with the case. So my first case is 31-year-old male uh, patient. No, he had no previous comorbidities and no addictions. So he had a history of 3 days of fever, and he came with slurring of speech, facial deviation, and that was noticed by relatives at 6 a.m. when he got up from the sleep. So then there
Can't
was
hear you
also
clearly.
hello.
Gopal, can't hear you clearly. Okay, why don't we come back to you after some time?
Hello.
Yeah, now it's better. Yeah.
I'm audible, sir.
Yeah.
Yeah. Okay. Uh,
Yeah, I think you are using two systems, so therefore echo is coming.
Why are you on two screens?
You are seeing two, one either on phone.
I will stop it from my screen.
So disconnect that web Zoom.
Okay, sir. Hello. I'm audible now, sir.
Yes, you are better. Come on. Continue. Continue.
Presentation is stuck up.
Go on.
So can we proceed with Dr. Sandeep till then?
Yeah, I think so. Let Dr. Gopal.
Sure. Dr. Sandeep, you may please start presenting your case.
Good evening, everybody.
Yes, Sandeep.
Uh,
Carry on.
Is my screen
Yes,
visible,
everything
sir?
is visible and audible.
Yes, sir. Thank you very much for this opportunity to present the case in front of esteemed panelists like you, sir. So, my case is very simple and very short. So, basically, is age just a number? This is what I want to convey. So, I'm presenting a case of a 12-year-old boy who presented to the emergency room with sudden onset difficulty in speaking, right upper limb weakness, right hemiataxia for a duration of 2 hours. And he had a history of off and on headache, which is there for last 2 to 3 months, and there's no family history of any stroke or hypertension. And this child also had no previous comorbidities. On examination, his BP was 130/90 on both the sides, right and left upper limb, and the heart rate was 80 per minute regular, and heart sounds were normal, no murmurs were heard. And on CNX examination, he was conscious but had a motor dysphasia and had a right upper limb weakness, with the right upper limb power in the distal group of muscle was 4/5, and in 5/5 in the proximal group of muscles, and he had right hemiataxia. So overall NIHS was 5. So we thought, okay, this looks like a acute stroke, whether ischemic versus hemorrhagic. The other possibilities was as he was having some headaches also. So edem and acute meningoencephalitis and malingering was also kept into consideration. So we urgently did a MRI, and the MRI showed multiple areas of diffusion restriction, and not a significant, with a significant mismatch in the FLAIR images and the ASL images. So the diagnosis of acute left MCA territory infarct was made, and the MR angio showed mild narrowing in the very proximal M1 MCA. So this was a diagnosis that it is a hyperacute left MCA territory infarct with a diffusion flare mismatch within the window of 2 hours, and there was no large artery occlusion, though there was some narrowing in the left MCA M1. So we did think of a reperfusion therapy. So IV thrombolysis was considered, and we thrombolized him with IV tenecteplase. 9 milligram IV bolus was given over 1 minute. There was no allergic reaction noted, and he had a significant improvement in his motor power and ataxia. And NIHS after 24 hours was 2. A CT head was repeated after 24 hours, and there was no evidence of any hemorrhage. He had multiple small hypodense areas of left hypodense areas in the left frontoparietal lobe, but the volume was significantly less as compared to whatever we were seeing, the diffusion restriction we were seeing. And these were his investigations. So nothing more significant in the routine investigation. The lipid profile was also fine, but he had a hyper homocystinemia. And the other, because he has a history of headache and a young patient, so we were thinking that there is some evidence of vasculitis or not. So workup regarding the vasculitis was done, The patient is admitted with us only. He presented just 2 days back. So these reports are awaited. And echo was done. There was no LA or left atrial appendage or any LV clot or any vegetation. And we are planning a Holter and thrombophilia workup and a cerebral DSA on him. And after the thrombolysis, this patient has recovered well, and he has just mild dysphagia, and the motor power has improved significantly. Now, so there's nothing new apart from the age. So what about the age? So this boy was just 12-year-old boy. And so now the issue is that whatever trials have been there for establishing the IV thrombolysis, whether we talk about the ECAS trial or we talk about the NINS trial, in almost all trials, they have taken the lower age limit as 18. So there hasn't been any study for the patients who are less than 18. And this was one of the meta-analysis. Again, they had patients in the range of 56 to 80, so no younger patients were taken. And the tenecteplase place trials also, whether we talk about NORTEST or NORTEST-2, both had an inclusion criteria of 18 years or older. And even the latest one, which is ATTEST-2 trial, again, age more than 18 years is their criteria. So this was not according to the guidelines. Even the guidelines given by the DGHS in India, they also say it has to be the age has to be more than or equal to 18. So now should we not treat the younger patients with IV thrombolysis? So because younger patients also have a significant annual incidence of stroke. So this is a data which shows that approved 13 per lakh children may be having stroke, and this will cause even more lifelong morbidity if the early intervention is not being taken care of. And there have been only case reports and a small case series for these children who have been treated with TPA. In US, less than 2% of children with acute strokes have been reported to be treated with TPA. In India, I could hardly find any significant report. In India, I couldn't find any significant case report apart from a few where they have been treated with IV thrombolysis. There have been a few case reports where the children less than 18 years of age who have been treated with mechanical thrombectomy, those with hyperacute stroke. So these are the two studies which I could find. So this was the TIPS study, that is a thrombolysis in pediatric stroke study, which was, it was funded by NINS only. And, but in this, they tried to include all those patients who were aged 2 to 17 years. But the recruitment was very dismal in this study, and this has to be closed earlier. They screened at 93 patients, 93 children, and only one could get enrolled into the study. So this was prematurely stopped. And this is one study which was a retrospective study of 48 patients who were aged, who were younger patients, including the age of 16, that is less than 18. In them, they found that thrombolizing these young adults, including those who are less than 18, was also beneficial. So the take-home message is that IV thrombolysis is a feasible option for reperfusion in pediatric strokes also. It is relatively safe, but controlled trials are required in this field. Thank you.
Prasanna?
Yes, sir. first of all, thrombolizing in 12 years age is one of the lifetime chances that any neurologist will have. I mean, in their career, and I must congratulate Dr. Anand for proceeding with it and doing well in the case. Of course, the NIHS was 5, and he did well. NIHS of 2. So I could come. I remember Green Journal article last year that there was some email study. I think it was some Lee or some other thing. So that there was an email survey of various pediatric centers who did IV thrombolysis with tenecteplase, and they had enrolled around 12 or 13 patients, and they have just mentioned that it seems to be safe and there were no side effects, but there is no mention of the efficacy or anything more than that. The youngest child that study mentions is around 5 years of age. So, but then the efficacy is seen today. Even this is new for me. I have never thrombolized any child. I could never get one in that time also. So I that question never came in front of me. So that's it.
Dr. Makaran?
Yeah, basically, stroke mimics are quite common in childhood. So that's why this, and no trial will take less than 18. So it has to be again individualized. Like earlier case, it was more than around 24 hours. So here age. So it is the treating doctor, and whatever he does in the best interest is fine. So everything can't be put in the rules and laws and this thing, because this Western country now right now, I mean USA, I had a grandson. So they say कि ये बच्चे को झूले में नहीं डालते because seeds is very common. I mean, seeds is very common in झूले में. Seeds is sudden infant death syndrome. Now my both son and daughter-in-law who are engineers, they're teaching me something like that. ऐसा नहीं करने का. You have to keep. You can share the room, not the bed. Conventional teaching in our side is माँ के बाजू में बच्चा सोता है. They go on so much protocol, so it sometimes irritates. But fine, I mean, you have grandsons, sir.
Yeah. So I face the same problem.
So these small things are causing problem, these seeds and all. So this stroke is a huge issue. I mean, so. But migraine, etc., can cause sometimes fishes, so trials may not be included. It has to be individualized. Of course, in this case, there was no migraine, there was ADC restriction also. So what do you get in migraines or ADC?
Yes, sir.
In migraine, what do you get on MRI? Diffusion restriction, but ADC is normal, no?
No. If you get an infarct, you get an infarct.
Okay.
If you get an infarct, you get a proper infarct. In migraine.
Yeah, okay.
And it's more posterior.
Yeah.
No, here, what I would think, I think there is no problem in thrombolizing. This is very difficult to do an RCT in young people. You won't get the numbers. Yes. And it cannot reach statistical significance. You have to have large numbers. You have to have 1,000 patients. I mean, 1,000 pediatric strokes, where will you get here? No,
Sir,
so it is next to impossible. It will have to be individualized, like what Makaranda said. But in your case, what I would think is that this is a case for doing vessel wall imaging.
Yes, sir.
Because there was stenosis of the M1.
Definitely.
So it could be a vasculitis. Another thing you could think of is doing a CSF study to see for herpes zoster antibodies.
Yes.
Many times this viral infections, they produce M1 narrowing and stenosis.
Yes.
So, other vasculitic workup will be negative. So usually it's an infective cause. And if you do vessel wall imaging, you may find an area of vasculitis, not atherosclerosis. It's unlikely to be atherosclerosis.
Yes,
he's
sir.
only 12 years old.
Yes,
so it's not going to be atherosclerosis. It's probably vasculitis. And very typical features you will find on vessel wall imaging of circumferential enhancement of the vessel. And the most common cause for vasculitis in M1 in children is herpes zoster. So recently we had a case like this. She was a older person. She was 40, and she had M1 occlusion, not occlusion. She had M1 stenosis and TIAs, and we sent for herpes zoster, which was negative. But what came positive was Epstein-Barr virus. So, many of these viral infections in young people can produce a focal vasculitis. And this is often the cause of stroke in the young. Now, whether thrombolysis works in these or not, we don't know. Probably it works because, if there's vasculitis and a thrombus sitting there, it probably works. And in your case, it seems to have worked. Another thing that which I found objection to is that in the window period of 3 hours, he came within 2 hours, there is no need to do flare diffusion mismatch. You just have to rule out hemorrhage and you should thrombolyze.
So because young children stroke
No,
mimic.
that's all okay. But
That
see,
was
within the window period, in
normally we
general, I'm
follow the.
talking. I'm
Yes,
not
yes.
blaming you. In general, I'm talking that, we want to do flare diffusion mismatch. That is in the late window. So in the
Definitely,
acute window, you don't need to do flare diffusion mismatch. You just have to
Yes, sir.
rule out hemorrhage. You may
And
not see the
thrombus.
infarct. In the early stage, in 1 hour, 2 hour, you may not even see the infarct on MRI.
Definitely, sir.
Especially in brainstem, to 100% you will not see. So in MCA territory, 30%, 40% you will see. What you have to see is that there is no stroke mimic and there is no
Hemorrhage.
hemorrhage. And then you thrombolyze. Otherwise, you see, we are wasting a lot of time by doing flare, mismatch, this, that, SWI. बहुत time जाता है उसमें, So as a general rule, if he's in the window, you don't need it. So no, that you have done it is fine, but you don't need it.
Yes.
So these 2 points I think I should make, and look for vasculitis. If you can do this thing, vessel wall imaging with a good 3
Definitely.
Tesla machine,
Mhm.
do let us know what you find, because I'll be
Sure, sir.
very interested to know what exactly is there. And do a
Sure,
CSF for herpes zoster antibodies, IgM
Thank you.
and IgG. You'll be surprised, you may find something.
Sure, sir.
So, very good case and very well presented. And I must say that all you young people are very gutsy and you're all going outside the guidelines. You don't have to follow guidelines all the time. Going outside guidelines is not a crime.
So,
Guideline is a guide. It is a guide. But in an individual case, you can take the risk. ऐसा कुछ नहीं है. You're not doing any harm. So these are the points I would like to make. Prasanna and Makaran, any last words on this case?
No, not
No,
about
sir.
this, sir, but cough syrup causing stroke in children. What do you see, sir? What's your
Cough
comment on
syrup.
that? Yeah.
When this ephedrine is there, ephedrine, it raises the blood pressure. And these cold tablets, all this D-cold and Sinarest and all this, these cold tablets which are over the counter, we have seen umpteen cases of brain hemorrhage because the blood pressure shoots up to 150, 160 in a young child, In 3-year-old, 4-year-old, 10-year-old, blood pressure goes to 160, 170, and they bleed. So I've seen many of these with these cold tablets. I'm very scared of them, especially all these OTC, not prescribed by doctors. But even doctors take this Sinarest and all. I say, Arey Baba, usme to ephedrine hai. Don't take that. Damn thing raises your blood pressure, yeah. Even temporary spike of blood pressure is dangerous.
Yeah, it's perhaps
And
more dangerous.
rapid rise like that, it goes up. That's very dangerous. So be careful of all these cold and cough tablets and syrups. I to never take only. Take Sedzin or something like that. And paracetamol. That's all. You don't need antibiotic also. Okay. So let's go on to your case. Next case, I hope it's now visible and this thing, you've sorted it out. Come. Next case. Thank you, Gopal.
Gopal is coming now, sir.
Hello.
Oh, it's still echoing. Okay, it's echoing.
Uh,
Hello.
Gopal,
I'm
go
audible?
ahead. We'll tell her.
Screen is not. Slides are not moving.
I don't know why you are using two logins. There
So-
is one Gopal Golap and there is one US Web Zoom. So two. That's why the sound is getting echoed. Is it that you are using phone also and desktop?
Sir, my sound is not visible.
काय
पिडियाट्रिक्सची आपण नाही केलं ना, मी तर नाही पाहिलं आणखीन. तो
Hello.
फोन येत-
Hello. Can I suggest one thing, Dr. Gopal, that since you are using two devices,
Yes, sir.
may I request you that you can, mute yourself in your one of the devices, as well as hold the volume of the speaker also. You have to
Okay, sir.
switch it off.
Okay, sir.
But
I'm audible,
it
sir.
will not come.
Hello.
Yes, now audible, and
Yes, you are audible
there is
and
no
better
echo
now.
as well.
My screen is visible.
Yes.
Yes,
So,
yes, doctor.
slides
Your
are
screen
not
is
moving.
visible.
Slides are not moving, miss.
Moving now.
Yeah.
It moved.
Okay. So, hello. So my first case was
I think we'll
33
take
year
only
old.
one case, huh? Gopal, we are getting
Yes,
late.
sir.
Yeah.
So my patient was 33-year-old male. He had history of fever and there was no comorbidities. So he came with slurring of speech, facial deviation that was noticed by relatives at 6 a.m. when he woke up. And that time there was also mild right-sided weakness, but he was able to walk. So they first reached to physician. That time, physician told them to go to neurologist, but relative was little bit reluctant because they thought it was not a stroke because he is only 33-year-old. So they kept the patient there only. But after around 12 hours, he again developed symptoms of, there was worsening of symptoms. So there was complete right-sided hemiplegia after almost 15 hours. So on arrival, his NIHS was 16 around 16 to 18. So next slide, please. So there was a ischemic stroke. It was mainly involving corona radiata and gangliocapsular area. We can see in the images. So next. So on flare images, there was just mild hyperintensity, intense signals was there, but there was no. There was some areas which was definitely only restriction was there on the diffusion images, and there was no flare hyperintensities. Next. So we can see in the angio images there was complete M1 occlusion on the left side. Though there was a small thrombus was there, small infarct was there. And next slide. So before thrombolysis, please play. So we can see in the video there was a complete hemiplegia on the right side. He was not able to speak. There was severe dysarthria was there. There was Broca's aphasia. So though patient was out of window, there was definitely diffusion flare mismatch was there. So I told relatives there was an option of thrombolysis and mechanical thrombectomy also, but relative was little means they were not agreed for the thrombectomy. So I decided to go ahead with the thrombolysis. So after few hours, almost after 2 hours, next video please. We can see that there was some improvement in the hand. He was able to flex, keep it in the flex position, and even in leg also we can see that there was some power around 2 to 3. He was able to extend the leg just after 2 hours of thrombolysis. Next please. Right. Next. Next slide. So I have repeated his MRI. There was no opening of M1. Though after 3 weeks, we can see that he was able to walk. Please play the video. Though there is a mild dorsiflexion weakness, we can see in the video, but he is independent. He is able to walk. Next, please. Next.
It's funny that he is holding child with his right hand.
Right, yes, sir. Next. Okay, and after 5 weeks, he was the dorsiflexion weakness was also reduced. So he was means there was significant improvement in even in his dorsiflexion weakness. So that was my case, and in that case we can see that the though he was out of window and we got the good result, and on repeat MRI there was a M1 was still occluded, but we can get the result and he was independent.
Very good, very good.
Thank you, sir.
Awesome. Excellent. Makrand?
No, sir, stroke, I mean, there's a traditional sentence in Bradley's, recovery is the rule if patient survives. So patients do recover, but then that's a significant recovery.
But this is a
he-
fantastic recovery.
Yeah. That's what, but then what do you say, sir? I mean, right hemiparesis patient, if he's carrying a child, should
Luckily,
he carry it
that
right side or left side?
infarct was deep and it was not involving, though MCA was blocked, the cortex and all was spared, only the deep white matter was involved.
A capsular warning, something like that.
There was no warning.
Yeah. It had completely,
but you see, I mean, that's what I was saying. No, that IV tenecteplase is working wonders. Every time we think that, "Arey, isko to empty karne ka," you know.
But now what you will do, sir, if this patient is done DSA after 3 weeks or say 1 month?
If he's improved fully, I won't do anything.
These people do, sir, now. I mean, the intervention people, they are
I
doing
know they
DSA.
do, yeah, but
It's like coronary angio doing every patient.
I
So,
don't
sir,
agree with
I
that.
have done his MRI, repeat MRI, still MCA was occluded.
Yeah. So there may be good collaterals of God
Yes,
knows
sir.
what.
Yes, sir.
You know, in MRI, you don't see the collaterals so well.
Yeah.
So you have to do CT angio 3-phase to
Yes.
see the collaterals. So MRI just gives you a static image. It doesn't give you a dynamic image.
Yes.
And, which CT angio can give or DSA can give. But I
DSA.
would not like to do a invasive procedure. I think CT angio three-phase gives you enough data. And if he's doing well, I think it's wonderful, yeah. It's just wonderful. So,
So this is like ICAD, no, intracranial
yeah,
hysterectomy.
it is an ICAD. And this ICAD is common in India in young people. And it's a big problem. Now, was he a smoker, drinker, all that
No,
type of
no,
stuff?
no, sir. But he had history of fever for 3 to 4 days before this
Ah,
happened. So
okay.
there may be some viral infection.
Vasculitis.
Yeah, something.
Yeah, we don't know. Yeah, so you see, viral infections, can precipitate stroke. Influenza can precipitate stroke. Herpes zoster can precipitate stroke. So, vaccine against influenza is a protector for stroke.
COVID was huge, no?
कोविड बाप रे कोविड में तो कितने स्ट्रोक हुए सो कोविड इन्फ्लुएंजा herpes zoster and maybe some other viruses which we don't know also can produce stroke. So viral infections are this thing. Mycoplasma, another one. Mycoplasma in young children can produce a stroke because APLA becomes positive. Temporarily APLA becomes positive with mycoplasma. So, infections can produce vasculitis, stroke, or they can precipitate stroke. They are triggers for stroke. They may not be the cause for the stroke, but they may be triggers for the stroke. Stroke triggers.
Yes, sir.
So, very interesting. And thank you so much, Gopal.
Thank you, sir.
Thank you. Huh?
Where do you practice, Gopal?
Huh?
I practice in Jalgaon, sir. I am a intervention neurologist. I have completed my neurology and intervention in Kokilaben.
Okay.
Excellent.
Yeah, under
And
Dr.
still
Bhatt
you didn't do
and Dr.
intervention.
So in Jalgaon, there was no still team. I am developing my team. There is little bit even there was not much awareness about intervention here. So,
Yeah, we have all gone through that.
yes, sir.
And I wish you all the best to develop your team. That is the
Yes, sir.
most difficult thing to do.
Yes,
And
sir.
unless
Yes,
you
sir.
have a team, you will not be able to do large number of cases.
Yes,
So
sir. Yes.
please develop your team, treat them
So
well, look after them, and they will give you dividends upon dividends.
yes,
So
sir.
develop
And
your
I
team.
am happy to tell you, sir. In last 1.5 year, I have thrombolized around 70 patients.
Are fantastic.
Yes, sir.
Abhi century maro.
Yes, sir. Yes, sir. Yes, sir.
Okay, so very
Yes.
good. Gopal, we are very, very happy to hear all your this thing. Sorry, we couldn't take all your cases because we are getting
No
late.
problem. I will share on next
No,
time.
maybe
sir.
you can do it next time.
Yes, sir. Yes,
You
sir.
come
Yes.
on the program next month.
Yes, sir. Yes, sir. Yes,
Tell
sir.
them that you come on the program because it's getting late and
Yes, sir.
I've also to go somewhere.
Yes, sir.
Okay,
Thank
so
you.
thank you everyone very,
Yes,
very
sir.
much. Yeah,
Thank you.
Kalpita,
Yes,
can you
sir.
sum up?
Yes, Dr. Chahuria. Thank you so much for all the wonderful cases. We really got to learn a lot, and I think like every month, this was also a major key takeaway. And I hope that all the doctors on board also got a good opportunity to present their cases. So we also had a very good audience. We crossed around 150 registrations, so that's a good count to begin with. And Dr. Makran, are you there?
Yes.
Sir, I'm extreme apologies for the initial goof up. There was a network issue. So I just wanted to take my time to do my part and introduce you to all our
In fact,
speakers.
I'm thankful. Dr. Ichapuria introduced me. So, I mean, it's the
No,
privilege.
I introduced him better and at a
Yes,
more
definitely.
level.
Yeah.
No doubt, sir, no doubt. I'm so sorry
because
for
we
the
know each other for so
inconvenience.
many years.
Yes,
Okay,
sir.
so
I'm
very
so
nice of you, Makran, to join from USA. Huh? What time is
Yes,
it?
sir.
What is the time?
7 o'clock, sir. I'm in Seattle. 7. Now it is 8 o'clock morning.
8 o'clock. Na? ठीक है. 8 o'clock
Yes.
is not like 4 o'clock.
Yes, sir.
Which place in
No.
US are you?
Seattle, sir.
Oh, you're in Seattle.
Yeah.
Okay, go to Mount Rainier.
Yeah, I had been, sir.
You have
No,
been.
this time only
Great.
just
Chalo.
babysitting.
Thank you,
Okay.
Kalpita.
Yes.
Thank you so much,
Thank
doctor.
you,
Thank you,
everyone.
everyone.